You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and a clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to Season 3 of the Medscape Type 2 Diabetes podcast series. Today we'll be discussing the American Diabetes Association Standards of Care in Diabetes, the 2025 updates. First, let me introduce my guest, Dr. Rozalina G. McCoy. Dr. McCoy is an associate professor in the University of Maryland School of Medicine's Division of Endocrinology, Diabetes, and Nutrition, where she also serves as Associate Division Chief for Clinical Research and the Director of the Precision Medicine and Population Health Program in the University of Maryland Institute for Health Computing. She has served as the co-chair of the ADA Professional Practice Committee. This is a committee that drafts the annual standards of medical care for people with diabetes, and she has chaired the 2025 updates and is also chair for the 2026 updates. Dr. McCoy, welcome to Medscape In Discussion Type 2 Diabetes podcast.
Thank you so much. It's wonderful to be with you today.
Great. Well, you have been chairing this committee, and I think the audience would be interested in hearing just a little bit about the process that you go through to update the ADA standards of care every year.
Yeah, this is a team effort that's led by the ADA Professional Practice Committee with support of an incredible ADA staff. The PPC, or the Professional Practice Committee, it's an interprofessional expert committee with physicians, nurse practitioners, pharmacists, diabetes care and education specialists, dietitians, behavioral health specialists, and others who have collective expertise in all aspects of diabetes management. So we first meet in January and get to work in early February, just a few weeks after the prior year's update is released. And then throughout the spring and summer, as you're hopefully reviewing and learning from the most recent standards of care, the PPC members dive into the literature to identify the major innovations in diabetes care, the key ongoing trials that are expected to be completed by July or so of the year, new drug and technology approvals and label changes, and importantly, the feedback and commentary that the ADA has received on the published standards of care and the living standards. So we meet regularly, I think weekly through the spring and summer, as subgroups of each section, and then the entire PPC for a 2-day-long working meeting to discuss the available emerging evidence, reach consensus on all the recommendations and the level of evidence for each. So once that's finalized, we begin working and writing. In the end, all PPC members review and approve the final version of the standards of care, which is what you read today.
That's very helpful. Thank you. So over the past several years, the standards of care have really emphasized putting the patient in the center of the decision-making and for the care for the person with diabetes. And of course, one important aspect of this is the importance of treating the whole person. Now, I know you could probably spend the entire 30 minutes talking about what that means, but could you perhaps talk about what you think are the most important additions from this year?
I am so glad you asked this because this is exactly the message we hope that all healthcare professionals caring for people with diabetes or otherwise involved in their care take away from the standards of care. People living with diabetes are people first. They have other chronic health conditions that require attention and management, are impacted by the context and circumstances in which they live and receive care, and may have different goals and preferences for care. So it's important that the standards of care supports a framework for high-quality, evidence-based, and comprehensive care that's individualized to meet each person's need. So there's a number of updates in the standards of care that really seek to do this. And I wish we had time to talk about all of them, but I'll mention a few. So first, we expanded Section 4, which focuses on the comprehensive medical evaluation and assessment of comorbidities, to include 2 new sections. The first is a subsection on dental care. So we recommend that people with diabetes should have a dental exam at least once a year because periodontal disease is both more prevalent and more severe in people with diabetes. It's also important to coordinate efforts between the medical and dental teams to adjust glucose-lowering medications before and after dental treatment to avoid hypoglycemia if the person with diabetes isn't able to eat. And then the second new subsection addresses for the first time the important topic of female sexual dysfunction. So female sexual dysfunction is very common. It's as common as sexual dysfunction is in men, and yet women are significantly less likely to discuss their concerns with their clinicians and to have them addressed. So we recommend that clinicians screen all women with diabetes or prediabetes for desire, arousal, and orgasm difficulties, and for signs and symptoms of genitourinary syndrome of menopause. Treatment of these conditions is multifaceted and the same as for women without diabetes, but includes additional focus on glycemic management. So the most important step here is to screen and detect female sexual dysfunction so it can be addressed. And then finally, we added through the entire standards of care important considerations for medication management in individuals of childbearing potential. So we talk about the importance of contraception counseling, something that hasn't really been a part of routine diabetes care conversations, but is incredibly important since the prevalence of diabetes, especially type 2 diabetes, among younger individuals has increased in the past few decades. Many glucose lowering, lipid lowering, and blood pressure lowering medications are not recommended for use during pregnancy. So the standards of care provide guidance on what to do for each of these medication categories. And for glucose lowering medication specifically, discussions should touch upon glycemic goals prior to conception, the time frame for stopping non-insulin glucose lowering medications, and the optimal glycemic management in preparation for pregnancy, if desired. And then because GLP-1 receptor agonists and the dual GIP-GLP-1 receptor agonists, they may affect the absorption of orally administered medications, including oral contraception, especially when you first start or increase the dose. So we recommend that individuals use a second form of contraception until the maintenance dose of these medications is achieved for at least 4 weeks.
There's a lot of information about the use of medications associated with weight loss in this document. Can you review some of the recommendations regarding diet and exercise in patients who are taking medications associated with weight loss or those who have had bariatric surgery?
It's really exciting to have so many effective treatment options for the management of obesity. But this also means that we have to work with our patients to make sure that they achieve and maintain their weight goals safely. So we stress the importance of physical activity, particularly strength training for adults and youth who are receiving weight management pharmacotherapy or who have had metabolic surgery. So weight loss, whether with pharmacotherapy or with metabolic surgery, induces both fat mass loss and the loss of lean body mass. This can lead to the development or worsening of frailty and sarcopenic obesity. If individuals who lost weight with treatment later regain weight, this weight is often regained predominantly as fat mass. And without strength training, very little lean body mass can be rebuilt. So strength training during weight loss minimizes the amount of lean body mass that is lost, preferentially supporting the loss of fat mass. And it's also very important for weight maintenance after weight loss. So I really stress to my patients that both aerobic and resistance or strength training physical activity are imperative for glycemic management, for weight management, and for overall health. And it's also important to screen individuals who've been treated with GLP-1 receptor agonist or the dual GIP-GLP-1 receptor agonist and those who have had metabolic surgery for malnutrition, which can occur in individuals of varying weight status, including those with obesity. So people who have lost more than 20% of body weight or lost weight rapidly, so more than 4 kilograms a month, should definitely be screened for malnutrition. We offer some suggestions in the standard of care for how to do that. One suggested screening tool is the Simplified Nutritional Appetite Questionnaire or SNAQ, which includes a few simple questions about appetite, food intake, and changes in eating habits. And if there's concern for malnutrition, it's important to screen for nutritional deficiencies and, of course, engage a registered dietitian nutritionist to help our patients prevent malnutrition.
How do you address the question about whether weight-reducing medications can be stopped once a patient reaches their goal weight?
This question comes up very often in my practice, especially as we're seeing drug shortages or limited insurance coverage for the most effective weight management medications like semaglutide and tirzepatide. So, broadly, we recommend that weight management medication that are indicated for chronic therapy. So, everything other than phentermine monotherapy should be continued beyond reaching weight loss goals to maintain all the health benefits of weight loss. Sudden discontinuation of weight management medications often results in weight regain and worsening of cardiometabolic risk factors like A1C, lipids, and blood pressure. So, clinical trials have shown that sudden discontinuation of semaglutide and tirzepatide results in regain of a half to two-thirds of the weight loss within a year. But we do not yet have robust data on what to do when weight loss goals are achieved, and the new goal is weight maintenance without further weight loss. So it's important to engage our patients in shared decision making and talk through the potential options, such as continuing the current pharmacotherapy at the lowest effective dose that is possible, switching to a less potent and typically less costly weight loss medication, or potentially even stopping a medication if coupled with optimized lifestyle management and close monitoring of weight. But I think this decision really needs to be individualized for each person and may require trialing different approaches to find one that is best for a given patient.
Those are really good recommendations, and I appreciate hearing your perspective on this. Well, on the topic of incretin therapies, many of us have struggled to help our patients access these medications in the face of cost and of shortages. Can you review the recommendations on what considerations we might have for our patients when they cannot access these medications?
Yeah, unfortunately, both of these scenarios come up in nearly every clinic visit. In Section 9, we provide recommendations for dealing with medication unavailability, whether it is because a medication is in shortage, like we have seen over the past 2 years with many GLP-1 receptor agonists or tirzepatide, or because of recalls, like we have seen with metformin, for example. So when the medication is in shortage, and when the prescription medication is not covered by insurance, some have turned to compounding pharmacies and outsourcing compounding facilities. But unfortunately, there have been many safety, quality, and effectiveness concerns with compounded products. It's important to recognize that compounded GLP 1s are not an exact copy of the FDA approved product because there's no available standard or chemical instruction guide for compounders to use to replicate the FDA approved product. So the compounded drugs are often salt versions of the FDA approved drug or come with additives that may impact effectiveness and safety and come in different doses and concentrations, leading to dosing errors and ultimately harm. So we therefore do not recommend use of compounded products that are not approved by the FDA. If a glucose lowering medication is not available, the next best thing is to switch to another medication in the same class or in a different class, but with a similar efficacy and safety profile. And when the original medication is once again available, we should reassess whether it's best for the individual to resume taking it or to stay on the new treatment plan if it works best for them. Now, cost is another important consideration. So the ADA, has and continues to advocate for affordable and accessible medications, insulin, and technology. And there have been several recent policy changes that lowered out-of-pocket insulin costs for many patients, typically to $35 per month for insulin. We talk a lot about this in Section 1 and also throughout the standards of care whenever we talk about potentially costly medications. So we have content with guidance on identifying cost reduction strategies, such as co-payment reduction cards, patient assistance programs, and encourage clinicians to work with other members of their teams, pharmacists, social workers, diabetes care and education specialists, who can be invaluable resources to help our patients afford and access the treatments they need.
Yeah, that has been a frustrating experience for us in our clinical practice as well. So, looking over the past several years, the recommendations for how and why we choose glucose medications has really changed radically. The new emphasis has been to choose medications based upon patient comorbidities to try to either prevent the complications or prevent the mortality and morbidity of complications rather than focusing solely on glycemic control. I believe this fits into the framework of the whole person care. Can you comment on some of the important patient characteristics that we should be considering when choosing an anti-hyperglycemic therapy?
So you're absolutely right. Our first priority in treating type 2 diabetes is preventing its complications, both short term and long term. So the choice of therapy is guided by the individualized prioritization of the need to prevent atherosclerotic cardiovascular events like MIs or stroke, reducing heart failure symptoms or hospitalizations, limiting the progression of chronic kidney disease, minimizing the impact of metabolic dysfunction associated steatotic liver disease, or MASLD, that's a mouthful, and supporting weight management. So, Section 9 of the Standards of Care is the most complex. It's also the most viewed and downloaded of all the standards of care. So, we simplified and streamlined the pharmacotherapy algorithm to make it hopefully more user friendly and also to incorporate new evidence on the optimal treatment of type 2 diabetes in patients with MASLD and MASH. So, to go through it quickly, adults with type 2 diabetes and established or high risk of atherosclerotic cardiovascular disease should be preferentially treated with GLP 1 receptor agonist or SGLT2 inhibitors for both glycemic management and for ASCVD risk reduction, irrespective of A1C. There have been no head to head studies examining which of these two medication classes is preferred in this context. The observational studies suggest them to be comparable. So, we recommend a shared decision making approach in consideration of the other health needs that may need to be addressed at the same time. Similarly, people with heart failure, either reduced or preserved ejection fraction, should be preferentially treated with SGLT2 inhibitors for both glycemic management and prevention of heart failure hospitalizations. New this year is the recommendation to consider using GLP 1 receptor agonists in individuals with type 2 diabetes, symptomatic heart failure with preserved ejection fraction, and obesity to reduce heart failure related symptoms. For individuals with chronic kidney disease who have GFR between 20 and 60 or who have albuminuria, we can use either SGLT2 inhibitors or GLP 1 receptor agonists for both glucose lowering, slowing the progression of chronic kidney disease, and a reduction of cardiovascular disease risk. But it's important to note that the glycemic benefits of SGLT2 inhibitors are diminished once GFR is below 45, in which context we still use SGLT2s, but for kidney protection and cardiovascular risk reduction rather than glucose lowering. In individuals with CKD whose GFR is less than 20, GLP-1s are preferred for glycemic management due to their low risk for hypoglycemia and cardiovascular risk reduction. Now, stressed newly this year for those with MASLD, MASH, or high risk for liver fibrosis based on non-invasive tests, GLP-1 receptor agonists, the dual GIP-GLP-1 receptor agonist, or pioglitazone, are preferred for glycemic management, though pioglitazone may not be a good option if the patient also has obesity. And then combination therapy with pioglitazone and GLP-1 receptor agonist can be considered with biopsy-proven MASH. And then as before, it's important to avoid hypoglycemia-prone medications, particularly in those at highest risk for adverse sequelae of hypoglycemia, and to choose medications with the appropriate efficacy to achieve glycemic and weight management goals. So in the algorithm in Section 9, we provide relative potencies of the available medications for each of these objectives to help choose the best medication for a given patient.
I was actually a chair of the professional practice committee when we first attempted to come up with an algorithm way back around what it was at 2012 or so. So I know in your practice and mine that we are using continuous glucose monitoring in our patients with type 2 diabetes on insulin. Can you review the new recommendations surrounding the use of a CGM in patients with type 2 diabetes when they're not on insulin?
This was an important update, which reflects the increasing body of evidence supporting benefits of CGM use in the management of type 2 diabetes. We recommend that clinicians consider using CGM in adults with type 2 diabetes treated with glucose lowering medications other than insulin to achieve and maintain their individualized glycemic goals, and this is level B evidence. Multiple clinical trials and observational studies have shown that CGM compared to blood glucose monitoring results in greater improvements in A1C, time in range, time below range, and time above range, as well as greater user-reported satisfaction. CGM can also support positive behavior change in food choices and therefore can support weight management. But we don't yet have the evidence to extend this recommendation to people meeting glycemic goals without use of glucose-lowering medications.
And what about CGM in the hospital setting?
We do recommend that patients who use CGM or insulin pump or automated insulin delivery systems who are hospitalized, that their CGMs, pumps, and AIDs be continued as clinically appropriate. Several studies have shown that inpatient use of CGMs can help detect and prevent hypoglycemia. However, CGMs are not currently FDA approved for inpatient use, so we need to use confirmatory point-of-care glucose testing for insulin dosing decisions and hypoglycemia assessment. And of course, use of any diabetes technology in the hospital is predicated on the local availability of necessary supplies, resources, and training, ongoing competency assessments, and implementation of diabetes technology protocols.
Believe it or not, I started my career before they started using finger sticks in the hospital, and we had a several-year process to try to convince the hospitals that they should be doing that. So this is kind of a flashback to that time. So we are increasingly aware that categorization of diabetes isn't always straightforward. Can you discuss the issue of atypical presentations of type 1 and type 2 diabetes, perhaps how to characterize them, and what to do if the diagnosis is unclear?
Yeah, I think this is a really important point. Diabetes is not a single entity, right? It's a group of metabolic disorders that's collectively characterized by underutilization of glucose as an energy source and an overproduction of glucose with increased gluconeogenesis and glycogenolysis. So it's not as simple as, someone definitely has type 1 diabetes or type 2 diabetes. We should suspect type 1 diabetes in individuals who are diagnosed at a younger age. We generally think about 35 years or younger, with personal or family history of autoimmunity, with a lean body habitus, with family history of type 1 diabetes. Those who don't respond as expected to non-insulin therapies, or who have been treated with medications like immune checkpoint inhibitors for cancer that cause type 1 diabetes. But these rules of thumb do not always rule out type 1 diabetes if these aren't present, because both type 1 and type 2 diabetes can present at any age. They can and do develop in individuals of different body types, including those who have obesity, and can present with variable degrees of acuity. I'm sure we can all think of young adults presenting with ketoacidosis and ultimately confirmed to have type 2 diabetes who can be successfully tapered off of insulin after initial treatment of their DKA. Similarly, older individuals, including those with relatively slow progression to insulin dependency, who we discover to have type 1 diabetes. So in any patient in whom we suspect type 1 diabetes, we need to test for islet autoantibodies. And we should check multiple antibodies because one may be negative. We check GAD65, right, IA2, zinc transporter 8, and islet cell antibodies. If antibodies are positive, we establish the diagnosis of type 1 diabetes. And we consider LADA to be kind of a type of type 1 diabetes in this context because ultimately patients require insulin therapy. If these are negative, but the index of suspicion is high, we also check C-peptide, just not in the context of recent DKA and making sure the blood glucose levels are slightly elevated. And if C-peptide is under 200 picomoles per liter, this too confirms the diagnosis of type 1 diabetes. And ultimately, if we're not sure, we treat based on the clinical scenario, provide patients with the tools to monitor their glucose levels closely, follow them regularly in clinic, and reassess in the future.
Today, we've talked to Dr. Rozalina McCoy about the updates to the standards of medical care for patients with diabetes. I want to thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on type 2 diabetes. This is Dr. Carol Wysham for the Medscape in Discussion Type 2 Diabetes podcast.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.